Good afternoon. My name is Sarah Kaluza, and today we're talking about implementing change and reducing hospitalizations. Today's agenda includes the discussion of hospitalization rate statistics and why this is important to us. We will then talk about Rogers' diffusion of innovation theory and how we can use this to implement a change in practice to reduce hospitalization rates. We will discuss why this theory was chosen as a delivery method. And last, we will talk about the steps in the change plan that we will use to implement a change in our work. So let's begin. We know that each year, rehospitalizations cost Medicare over $17 billion. We also know that patients who do return to the hospital within 30 days of the initial discharge have a 70% mortality rate within that first year of the initial discharge. HealthStream.com in 2019 stated that 1 in 5 elderly patients are rehospitalized in that first 30 days after discharge. Those are some pretty significant numbers. So why is this important to us? This is important for a few reasons. First, positive patient outcomes are the goal for all of us. Beginning at admission, our goal is to safely return the patient home and prevent them from having to return. Returning to the hospital within 60 days of discharge is not only costly for Medicare, but it is costly for the patient and for the organization. In the future, Medicare will be using a value-based purchasing model for payment, and this means that payment will be based on patient outcomes and patient satisfaction, both of which are affected by patients having to return to the hospital. Now that we have some facts, let's talk about what we can do to reduce the readmission rates. Let's begin by reviewing Rogers' diffusion of innovation theory. According to Wayne Lamort at the Boston University School of Public Health in 2019, the diffusion of innovation theory was developed in 1962 by E.M. Rogers as a way to describe how an idea or innovation gains momentum and spreads through a specific social system. The idea is to get a person to believe in an innovation or needed change and get them to adapt that change and help it spread through the social system. Lamort describes the following stages in which a person adopts an innovation for use. First, there is awareness of the need for innovation. In other words, what is the reason for the needed change? Once we have enough evidence, we then make the decision to adopt or reject that innovation. The innovation is then put into practice to test, and hopefully the innovation we present is adopted and continues to be used. Another way to think about this theory is that there are 5 steps to implementing a change. The first is knowledge, when the change is presented and the staff is educated. Then there's persuasion. Something to consider here is using someone as a change champion to persuade their peers. Then there's the decision stage where the adopter decides to accept or reject the change. Implementation, or putting the process in place. And last, confirmation, when staff see the benefits and continue to use the change. Why should we use the diffusion of innovation theory? And how does this happen? So adoption happens in stages. People will adopt change at different speeds. There are innovators, the early adopters, the early majority, late majority, and the laggards. Each level of adopter influences the next to encourage the adaptation of the needed change. This is important in healthcare because it allows staff to adopt the change and encourage each other to adapt and accept the change as well. As each group adapts and recognizes the benefits of the change, it will be more easily implemented and followed through. Now let's look at change theory in practice. So we see here that change process begins at the senior leadership level. They have identified rehospitalization as the clinical issue to be addressed. Remember back to the beginning of today's presentation, we discussed the needed change to decrease the rate of rehospitalizations. The multidisciplinary team then gathered research on the issue and put together a plan that addresses the issue at hand. The team has decided that a new intervention needs to be put into practice. This intervention will be to obtain a physician order for a home health referral for those patients that were identified as being at risk by the hospital case managers or nurses. This information will be used by the unit leaders to educate their staff on the clinical issue, the new intervention that is to be used, the benefits of that intervention, and the process. Clinical staff will begin implementing the new intervention, and leadership will continue to assess the rehospitalization rates and send updates to the units as results are seen. Change is difficult for many, so by using Rogers' 5 stages of change theory, we can hopefully increase compliance as the clinicians, otherwise known as the adopters, accept the change and continue to promote it as a useful intervention. Our last slide is our implementation plan. It begins with staff education, where education will be provided that is unit and discipline specific for that new intervention. A start date will be determined to begin using that intervention. Continue to promote at staff huddles, meetings, unit communications to increase exposure to the intervention and the benefits. Repetition can increase awareness and encourage staff to use the new intervention. There will be a 6-month review where leadership will look at the initial rehospitalization outcomes and the use of the intervention in 6 months. If rates have not been positively impacted, re-education will be done to increase compliance of the use of the intervention, and the intervention will also be reviewed for any needed changes. And then last, in 1 year, there will be another review of the outcomes, and again, we will reassess compliance and the intervention for effectiveness. The last slide I want to talk about is our implementation plan timeline. First, you will see there is staff education that will be provided that is both unit specific and discipline specific for how to use the new intervention. A start date for implementation will be determined and communicated once it is finalized. Until then, continue to promote the new intervention at staff meetings, unit huddles, and in any other staff communications. Repetition increases awareness and encourages staff to use the new intervention. There will then be a 6-month review of the initial outcomes and how frequently the intervention was used. If rates have not been positively impacted, re-education will be done to increase compliance with the use of the intervention. The intervention will also be reviewed for any needed changes. Last, we will have a 1-year review of outcomes and again reassess compliance and effectiveness of the intervention. Implementing change is a big job and takes teamwork and coordination to become an everyday practice. Please reach out to me if you have any questions or would like a copy of the presentation. Thank you for your time today. I look forward to your feedback.